Hello and welcome everyone to OpenTempo's webinar series, Learn from Leaders. Today we're going to be talking about perioperative surgical home and staffing challenges and best practices with our presenter, Dr. Zev Kane. Just advance the slide. So just a few notes here. My name is Rich Miller. I'm the founder and chief strategy officer of OpenTempo. Before we continue on here, I just want to clarify a few details. First, be sure you can see the questions box in the lower right of your screen. Also, to prevent background noise, we've put everyone on mute. So use the question box to ask questions or make any comments as we go along. Also, we have set aside 15 minutes for question and answer. So our presenters will respond to your questions then. If you are unable to locate the questions box, you can email my colleague, Jennifer Michelle, with your questions at jennifer.michelle@opentempo.com. So first I'd like to introduce Dr. Kane from University of California, Irvine. Dr. Kane is the Associate Dean for Clinical Research and the Director of the Center for Advancement of Pediatric Health and the UCI Chairs for the Council of Chairs. He is recognized as an international expert in the clinical management of perioperative fear and anxiety and management of children undergoing invasive medical procedures. He has worked with more than 3,000 children and published more than 150 articles, changing the way children are treated during invasive medical procedures before and after surgery. So without further ado, I'm pleased to introduce Dr. Kane.
So before we get into that, just to get everyone a little involved, we're going to do some polling questions as we proceed through this. And so I want to launch this first one, and you'll be able to actually respond from your computer. So the first question is, do you currently use the perioperative surgical home model? So you can answer. We're going to just wait a moment and let people respond, and then we'll be able to show the screen and show the results. Okay. So, take another second or two. Again, if you currently use a perioperative surgical home model, indicate it. Okay. Okay, so we had 9% say yes and 91% say no. So
okay. Well, it sounds like this is a here to talk about perioperative surgical home and get people thinking about the next stage of their steps towards perioperative surgical home.
Okay, so the next one we do, and then we'll have a few more later in the event, is your organization exploring the idea of launching a perioperative surgical home? So again, if you want to respond to that, is your organization exploring the idea of a perioperative surgical home? And we've only got about half of the people voted so far, so the rest of you, if you want to click yes, no, or not sure, then we'll close the poll and see the results. Okay. Looks like most people have voted by now, so the results are 65% yes, a full 31% are not sure if they're exploring it, and 4% no. Okay, back to you guys.
Okay, so Dr. Kane, I'm going to advance to your first slide and we can get started.
Wonderful. Good morning, everyone. Is the volume sounds good?
Audio sounds great. Thank you, Dr. Kane.
The introduction you've read about was interesting for me to hear because that actually since I moved to University of California, medical officer, I became highly involved in the operations of the operating rooms. And then at 2012 is when we started to explore the perioperative surgical home. And so for the past 3 or 4 years, this has been kind of the main thing that I'm involved with. And by now have lectured probably hundreds of lectures on the topic, as well as provided some consultations on this topic and how to start it. So that's kind of what we're going to do today over the next 45 minutes. Next slide. I come to you from Newport Beach. The weather here today is somewhat cloudy, but I know I was in Washington, D.C. yesterday. It was wonderful. So this is a good time of the year for everyone to enjoy the weather. Next slide. So when we talk about the perioperative surgical home, we really have to appreciate that we're talking about change management. Rich, your slides are a bit too advanced. When we talk about change management, we really need to follow a model like that. And the model I'd like most likely to follow is the model that comes from John Kotter. And John Kotter is a speaker from the Harvard Business School, has published multiple books. Some of them are called Leading the Change. And John Kotter is talking about 8 stages. Go back 1 slide, please. John Kotter is talking about the 8 stages of change. And the first of these 8 changes that will kind of follow up throughout this discussion is building the burning platform. And the bottom line is that if in your organization you're thinking about a perioperative surgical home or ARIS or whatever you want to call that process, unless you're going to establish the case for it, nobody's going to follow you. So just because it's the newest, fanciest thing, that's nice, but people will not do it unless you demonstrate for them that, hey, we need to do this. So let's start this presentation by talking about why should you do this altogether. Next slide. So let's look at how your hospitals are doing right now. The reality that for 2015, most hospitals are really into investment. They're investing heavily into population health. They're still into the business of information technology, and they're really trying to build lower acuity healthcare settings. They are reliant more and more on the government for payment right now. And as I'm going to talk about later on about bundle payment, that means that for your hospital at the moment, they are really relying on the government as paying the bills. Next slide. Now, if that was kind of not enough, about a year ago now, the Secretary of Health and Human Services has announced that she is now going to move the payment for your services that the hospitals are getting paid to be tied to quality and effectiveness measures. 50% of the shipment will be happening by the end of 2016. That is going to really increase and becoming very acute in 2018. Next slide. Now, what's really interesting is that there has been a significant acceleration of that timeline. And while personally I beginning thought, well, that's fine, but that's just the government payers, and who knows if the private payers will follow, the answer basically came out very clear. And as you can see at the bottom of the slide, these are some data from Aetna and United and Anthem and Cigna that not all are focusing on bundle payment, and they're all focusing on the concept of payment for quality and value. Now, next slide. The movement toward outcome and efficiency has really been accelerated. And if you look at the hospital value-based payments, you see that at 2013, they're mostly focused on clinical processes. So what does that mean? It means, well, did you give the antibiotics for skip? Yes, no. And I know all of you remember how we all were focused on it and we all achieved 98 or 99%. So the government basically said that's nice and started to move from there on. And now on 2016, for example, you can see that they're going to focus on outcomes, they're going to focus on efficiency, on clinical process, and on patient experience. So the old model of just let's make sure the antibiotics are in is kind of gone. And the government now is coming up with new models such as MACRA and MIPS, which I will talk about later on very, very briefly, are in. And all these models basically say that the hospitals are going to get paid for quality. Now, next slide. This is not only about the government. The providers are also getting squeezed by the funding agencies, let me call it that way. Whether it's PQRS, whether it's MACRA, whether it's MIPS, and I'm not going to talk about that. And by the way, the ASA has some very, very good material they have published on that topic, as well as on the importance of why you should all be members of QCDR. Bottom line is that we are not going to be saved from this. And yes, right now, most bundle payments are to the direction of really type A payment from the government, but they're moving slowly but surely into type B. Now, if you think bundle payment is rare, next slide, all you need to do is go to a website of CMS and just type in bundle payment. This is from, I think the slide is a bit out of proportions here, but this is from April 1, and as you can see, how many hospitals around the country are already in bundle payment. Next slide. Now, if you thought that that was enough, here comes the CJR, or now as it's named, CJR. I'm going to talk about that for a second because that's a very important topic. So as of April 1 of this year, there are 800 hospitals in this country that are mandatorily participating in this initiative of bundle payment for hips and knees. You don't have a choice in the matter. There are about 51 areas in the country that were selected by CMS. They are the most populated areas. And if your hospital just happened to be in those areas, you're part of this. It's right now covering, again, only Part A, which means only the government and not your payment. But I promise you that your institutions will come to you and say, how are you going to help me, the hospital, control the costs? They're going to do the same thing to the orthopedic surgeons. And just to give you an idea, the payment now to a hospital will range, but the average payment will be about $24,000 for the entire episode of care, including skilled nursing facility. Now that's going to bring some huge reduction in what hospitals are getting paid, and hospitals are now getting ready to figure out how will they improve their operations so they can sustain this hit. Next slide. Now, this is what basically it means. It basically means that in that payment you'll have the acute care, next slide, plus the estimated care before, next slide, next slide please, and post-acute care as well. Why don't you just click 3 times for all of these to come up. And as you can see that now it includes the 3 days index admission through 30 days after hospital discharge. All included really in one big payment. Next slide, please. Next slide. Yep. So essentially now the entire acute episode is going to be paid as one. Now, in the parallel processing, remember I just talked about why should you look for changes? Why should you make any changes? So one thing is we said, well, the payment structure is changing. The hospitals are changing. You need to streamline your operations. The other thing that's happening is the digitalization of healthcare in the United States. If you go to these meetings, this one is Health 2.0. It's a picture that I've taken of the actual meeting. And one of the people who sits right there is the Secretary of Hospital and Health Services. And what she's saying again is that a lot of what healthcare providers can do can be more efficient if they use technology. Next slide. And what she means by that is Watson Health. And Watson Health, as one example, came up from artificial intelligence that first was used to entertain us and basically to win in Jeopardy, but now became a very serious healthcare platform that is being licensed out by IBM. And IBM actually thinks this may be their financial future altogether. So next slide. There is a huge pressure now on the providers to deliver high-value care, right side at the top, and at the same time you have digitalization of the U.S. healthcare system. And just to give you an idea, we have right now over 160,000 applications now in healthcare. Now the overwhelming majority of them not being used, but obviously this is a direction we're all moving into whether we like it or not. Now that's nice, but how all of this is relevant to the perioperative care? Next slide. And so if we look at the perioperative care, we kind of have to ask in business what's called the voice of the customer. So I know we think that we deliver excellent care, and we do. The question is, though, what do other people think about it? And if you ask hospital administrations, if you ask patients, they will tell you that, yes, but your costs are very high. And yeah, we produce most of the revenue to a hospital, but at the same time, we also are 60% of the hospital expenses. The patients will tell you that there is a fragmentation of care, and I can attest to you by, I've now worked with about 7 hospitals to implement this, and everywhere you go, the story is the same. The patient goes to the pre-op clinic, if there is one, then the patient goes to the surgeon's clinic, then the patient goes to the pre-op area. Those 3 entities don't really talk to each other. And by the way, optimization of the patient doesn't start until the patient is cleared financially. And by then, it's too late. We are focusing on patient reimbursement. There is a lot of outdated, and I put the word surgical, but really it's surgical anesthetic traditions, and we do a lot by how did the last case go versus what's the most efficient and evidence-based way. There is a process variability. There is a lot of variability in ordering consults and getting blood work. I'm sure that all of you by now heard the joke that is reality, which is what is the best predictor for obtaining blood from patients during the hospitalization? And the answer is the sun comes up. It's literally every day we take blood from our patients. It's not clear how we change the management, but we get blood. Now, last but not least, the post-operative care is very disorganized and very disjointed. And in the OR, we all are very clear mission-driven, have a great teamwork. But once you leave the OR, the patient is kind of even never land in the post-operative floor, and it's being managed by surgeons or hospitalists, and the communication is not best then. And by the way, once those patients leave home, then really all things kind of fall apart, and readmission issues becoming a big deal. Next slide, please. So we're going to have a question here, and the question is your hospital pushing to reduce readmissions, 30-day readmissions?
So I'm going to just move in and set the poll live so everyone can respond. Thank you, Dr. Kane. So everyone, if you want to just respond, now we'll take a few seconds to do that. Is your organization pushing to reduce hospital readmissions? So waiting, coming in, got about 72% voted. We're just going to give it a few more seconds. And is your organization pushing to reduce hospital readmissions? And those are the results. So 85% of the respondents say yes, 11% is not sure, 4% no. Okay, back to you, Dr. Kane.
Okay, so just a comment about the results. If you are in a specialty organization, such as a cancer hospital, or that, then the answer may be yes, we don't really care, but we're exempt. If you're not, for the 11% that are not sure, I promise you that the answer is yes. Every hospital is now doing it because the hospitals are not getting penalized as of next year if there is a 30-day readmission. So what does that mean? It means if the patient comes back to the hospital for any reason at all, for the next 30 days after an episode, the hospital is not getting paid, which is a big deal because in the old days, that's how hospitals made money. Now, let's put all these problems across the perioperative continuum, and without getting into many details, you can see how the entire perioperative continuum is featured in front of you, and you can see how there are problems in care in each one of these points, and there is an opportunity to fix all this. Next slide, please. Now, I assume most of the audience, next slide, please. I assume most of the audience are clinicians. And so we really need to develop strategy with the hospital on how to align ourselves and how to build a cultural alignment, an economic alignment, and a clinical alignment to come up with a model that works for everybody, to come up with a model that everybody benefits from. And that's where the quadruple aim is. And so, you know, the classical triple aim is, of course, better clinical care with a better patient experience with a lower cost. And now the fourth aim is also to make sure that you achieve clinical alignment across everybody. So I'm going to now run through a short series of slides and just showcase you one hospital that have done this. And then we can generalize some statements from that. Next slide. So if you are thinking about a perioperative surgical home, you really have to first build a team, and you really have to choose a project. Now, when you build a team, the underlying theme is going to be the perioperative surgical home, or ERS, is a team sport. It is not an isolated event. It is not something that can be run by anesthesiologists or surgeons or hospitalists or hospital administration or the nurses. It's a team. And if you look at this picture above, you have the chair of orthopedic surgery, the chief operating officer of the hospital, and the chair of anesthesiology, and a joint surgeon. And that's the initial team that we have launched in 2012 when we first launched the project. Now, as I said before, since then I've launched this probably in about 7 or 8 other hospitals, but the team really never changes. Next slide. Now, the next question is, what project are you going to choose? Well, this slide was created actually before the CJR initiative. And the slide basically said why many people are choosing joints to start with. And the reason is because all of us hopefully are getting old, right? Because the alternative is less enticing. And as we get old, we need replacements. We need replacements for the hip, and we need replacement for the knee. And the cost of this procedure is going up, but the reimbursements are staying the same while implant cost is going up. What does that mean? It means that the hospital are getting bigger and bigger problems of financing this. Next slide. In fact, when you look at data that is average across all hospitals in the U.S., and you're trying to look at cost savings in various DRGs, you figure out that the highest DRG is vaginal cesarean delivery, but the number 3 in a typical hospital is joint replacement, and by the way, number 2 is lumbar or lumbar fusion, right? So what does that mean? It means that orthopedics is number 2 and number 3, and by the way, number 5 in hospitals where you can save cost. Next slide. So we showed you the team and we showed you the project. Now let's go back to the team. And this is the membership of the team. And as you can see, there are a lot of members on this team. There is physicians, there are patient experience people, pre-op nursing, quality, case management, critical care, nutrition. In fact, the first time we did a retreat, there are about probably 67 people. And the last retreat I've done at Winthrop University Hospital maybe 4 weeks ago, we had about 54 people. And in that 54 people, you have really all those domains. And by the way, the pictures at the top are actual people from those retreats. Next slide. Now, when you build a plan, you obviously have to say, okay, I want the perioperative surgical home, and they'll say, well, what does that mean? Well, it means that you need better coordination of care. That's nice, but what is it going to bring to? And the answer is it's going to reduce the cost of care. And the next question is going to be how. And then the answer is, well, it's going to decrease the length of stay in the hospital. It's going to make sure that patients are discharged to the right place, not skilled nursing facility is possible. It's going to make sure that your readmission rate is lower. And all that is going to happen because of reduced complication rate and because of standardization of practice. Next slide. Now, we talked a lot about 30-day readmission rates. And as you can see, next slide, the readmission rate among the medical conditions is 1 out of 6 patients. Next slide. And among the surgical patients, you can see that 1 out of 8 surgical patients is readmitted to the hospital within 30 days in 2010. That's across the entire United States. And by the way, as I've indicated before, the hospitals are not going to get paid for this or getting fined for this as early as next year. And that's why your hospital is focused on this. Next slide. And if you look at the map of the United States and you're looking at spending for Medicare enrollee, and then you overlap that map with the readmission rates map, you see that it really very strongly correlated. And that's why the government is so focused on the issues of readmissions. Okay, so we have decided, going the other way, we have decided about, sorry, go ahead, next slide. So now we're going to talk about the plan. And so we talked about the expected deliveries. And next slide, we're now going to talk about the model itself of the perioperative surgical home. And I'm going to spend a minute or two on this slide. So the slide here has several components. You can see there is a pre-op, intra-op, post-op, and post-discharge. On the top, you can see there is a patient-centered medical home. Below, you can see that it sits on mobile health or EMR. And then you have all the supporting microsystems. Now, we talked about the supporting microsystems, right? It's a very fancy way to say that everybody needs to be on the bus and everybody needs to work together. mHealth, again, is a fancy word to say that the best way to hardwire all of this is if you can use your electronic medical record system, and you can use some of those apps that are just coming out right now. So let's focus on the 4 domains here. So pre-op. If you need to remember 4 or 5 things about pre-op, think the following. Think optimization of underlying diseases, such as diabetes, hypertension. Think about prehabilitation of patients. That means exercising and the right diet before surgery. Think about risk stratification. That means that you're identifying the patients who are at high risk to have post-operative complications before the surgery ever started, right? And then you know where to focus all of your efforts. And last but not least here, think patient-centric. You really need to educate the patient on this entire process and tell them what's going to happen and standardize all this wonderful material. Intraoperatively think ARIS and think goal-directed therapy. And those are the areas that are probably you're most familiar with, so I'm not going to go into that. But also think about standardizing your anesthetic plan, right? Now, I'm not for standardization of individual patients, but I'm all for standardization of processes. So what does that mean? It means that, for example, when you talk about optimization for patients of diabetes, you really should have a protocol for it in your clinic or in the surgeon's clinic. So everybody agrees what's the hemoglobin A1C that's beyond it, you're going to do something or not. And everybody's going to agree how you're going to handle anemia. So you need some protocols, guys. There's no really two ways to get around this. We don't want to become cookie cutters, but at the same time, we have to make sure that we manage anemia the same way, regardless of what day of the week it is and who is at the pre-op clinic. Post-op on the floor is where there is a huge opportunity. And that's because while in the OR we have this amazing team that takes care of the patients, on the post-op at 10 o'clock at night when the patient has chest pain, we don't know who's going to handle that patient. Is it the on-call first-year surgical resident? Is it the hospitalist from home? Is it the private doc from home? Is it the surgeon from home? And that's why most of the cost of complications right now happen all in the post-operative period. And most of the complications, by the way, are medical complications. So you really need to figure out a way to handle that. And we can talk later on about various ways you can create a healthcare provider system there that's supervised by anesthesiologists, by hospitalists, by surgeons. Either way, you really need to make sure that if you build a clinical pathway, these people are following the clinical pathway, and these people are focusing and moving the patient through the hospital, out of the hospital, and they communicate now with the primary care provider to make sure that the patient doesn't come back to the hospital. Because typically these patients, while they're being discharged, are getting into this black hole, and nobody knows where they are, and they just end up in the ER again. So if you want to build a perioperative surgical home, you really have to now take care of the part after that as well to make sure they don't come back to your hospital. And we can talk about that more in detail. Next slide, please. So you're in the elevator, and somebody asked me, what is the perioperative surgical home? This is an example of a pitch that you should use. And if you notice in this pitch, there is not one word about anesthesia, surgery, hospitalist, nursing. It's not about the team. It's about the concept. And it's all of us need to work together to break what I call these false boundaries that everybody's kind of doing their piece and nobody is kind of willing to touch anybody else's piece. So that's what the initiative is. Next slide. Now, we talked already about how we start the project, so let's get a little bit into the details here. You have to start this with a kickoff meeting. And this picture is from an actual kickoff meeting that I led. And as you can see, there are a lot of people in that room. Now, the person in the middle who is wearing a blue sweater and a shirt is actually the director of perioperative IT. The guy behind him who is standing with glasses is actually the director of the blood bank. And then around them you have surgeons, you have anesthesiologists, you have hospitalists. But I really point out these two people to make sure you understand that everybody needs to be there because it's a project that is going to incorporate everybody. The agenda is going to be the commitment to the project. And essentially, part of the agenda is going to talk about what gaps do you have in the system at the moment. So typically, you will administer the survey ahead of time to know what gaps you have. And then part of the agenda will be to do some process mapping, identify what gaps you have, so then you can implement the framework that I've outlined earlier. Next slide.
Dr. Kane, I'm going to... Dr. Kane?
Yes.
Sorry, I'm going to just cut in for a second. We have a question. One of our attendees would like to know if you know of a perioperative surgical home that would be willing to share some of their protocols.
Why don't you guys contact me privately after this conference, and in the last slide you're going to see an email. I'm going to give you my email already. So it's my first initial and last name, so it's ZKAIN at ihgconsult.com. And that's one of my emails. And if you send me an email, I will answer your questions specifically. And the answer is yes. But please please ask me directly.
Okay, thank you.
Great. Yes, let's make it interactive, so please don't hesitate to stop my flow of words here. It's always interesting to actually respond to questions. So here's the project phase, and you can see there is an initiation phase, then there is a control and monitor phase, and then there is an execute, and then a close. Next slide. You need a project charter, and in the project charter, you're going to put in exactly what you want to achieve with the Perioperative Surgical Home. These are very easy to find everywhere. And again, just ask me. Next slide. Now, as you sit down during that meeting, you really have to decide who's on the team. And so this is a kind of a rough guidelines to make sure you create who is on the team and who is not on the team. So you see you have power and interest, and you have 4 quarters. So you definitely want people who are high interest and high power right there. People who have low interest and low power, you probably can just tell them what's going on. So you really need to kind of make sure he's involved in this, put them in the first quarters, and just make sure that they're there. Now, I just want to warn the audience here. I know that one of the common questions is, well, just give me the protocol and I'll implement it. I wish life was so simple, and I'll give you an example. Think about how frequently you have picked up a book on losing weight or reading faster or any of those big episodes in life, and how many times it was effective just from reading a book. So I would say it's the same thing. Yes, you can get the protocol, but just reading the protocol is not going to help because people will not agree for the protocol to be implemented. So you really have to go through a process of change for people to accept the protocol. And by the way, the protocol has to be individualized to your location. Otherwise, the surgeons and your anesthesiologists are not going to agree to do it. They're going to say, that's a very nice protocol, but it's not my protocol. So please, you really have to understand there is a process, and you can't shortcut it just by introducing a protocol, because people will just not do it. Next slide. Now, it's very important also when you talk with the hospital administration to make sure that they understand that this is a good thing for everybody. Because again, if you think that this can be a project of just anesthesia, it's just not going to happen. There's going to be so many barriers. So everybody needs to agree on this, and this is one of the ways to do this. You need to basically build a business canvas or a business plan, depending how contemporary you are. But basically there you need to outline what's in it. What's the return on investment? And so next slide. This is a table that typically will end up from there. And this table needs to be gotten from your hospital, from your data. But the bottom line is you can see that this is a real example of how we were making, we're predicting in the business plan to make $1.54 million for the hospital if we will implement this plan. So when you start with this and you show the hospital how much money you can make or they can make, then obviously everybody's much more receptive for any changes, and you will need changes in the process. Next slide, please. So these are just some projects of how to manage this. And each of the hospitals that you work in has a quality and safety department. Those hospitals are typically excellent in giving support to everybody when they want to do projects. So you yourself do not need to be an expert on Six Sigma or Kaizen. So you need to reach out either to your hospital administration or to somebody from the outside who can do these things and can help you to run this project. Next slide, please. Classically, this is how you run this project. You have a pre-op team and an intra-op team. an immediate post-op team, a post-discharge team, and then one more team of metrics. Now, this is not the only way to run the teams. Another approach may be to have a clinical team, an operation team, an IT metrics team, a patient-centric team. So you can have teams either way, so either cross-sectional or longitudinal, as I like to call it. But the bottom line is that you need to divide your powers into teams, and each one of them needs to work on its relevancy or on its relevance part. If you're going to ask me right now, well, how long a project like this will last, I'm going to tell you between 3 and 6 months. That's the time it will take you to basically gather everybody together, start working on these changes, implement the changes, and make sure that they're actually sustainable. The good news is that once you have done one of these, the next one will follow up very quickly. And for the next one, you don't need 6 months because you have built all the infrastructure already. Next slide. One more picture here to emphasize to you, next slide, of how people work together. And in this picture, you can see the guy who is holding his head is actually a spine surgeon. And this is how, when we're outlining the process pathway in one of the hospitals I work in, he didn't realize how complicated this actually is. And the lady, first lady on the left-hand side, is Director of Nursing at Critical Care, who again is realizing what this process is. Next slide. So I'm going to dive into some details for the next 2 or 3 minutes, and then we will stop because we want to leave some questions. So this is the preoperative period, and we talked about optimization. And so specifically for joints, you should have mandatory classes, and you should standardize orders such as for VTE. Next slide. And basically you have optimization, which involves patient engagements and improve outcome. You can see smoking cessation, diabetic control, patient engagement, clinical pathways, and involving the patient in direct decision making. Next slide. Intraoperative, we talked about, mostly it's GDT and ERAS and a lot of standardization of work. I don't like to talk about standardization of implants within this context. That's not something you want to start right away. It's typically a very emotional issue for the surgeons, and so you really want to optimize the processes rather than just immediately run after the implants. Next slide. And then the post-operative care, as I said, it really needs to be coordinated either by healthcare providers, or by actual anesthesia personnel. Depends on your hospital. The healthcare providers is a much more feasible model. I'm working right now on a model with hospitalists, and that model works very well as well. Next slide. And so for those of you who have a pre-op clinic, I wish we would have remembered to put in a question about that. The pre-op clinic has a huge role in the management of these patients when they go home, because you have an opportunity to then follow up these patients and to understand, to make sure that they're not getting readmitted. And there are various ways you can do that. I can tell you one way that I've just discovered in a hospital is to use the urgent care clinic. So now the patients who have part of PSH, when they go home, they're requested, if they have any issues at all, to come back to the urgent care and not to the ED. And the urgent care is ready for those patients that know that they're part of the PSH, and they know that if they show up post-op, they will call up somebody from the PSH team who likely knows these patients and can easily handle them much better than end up in the ED and getting readmitted. So that's a more contemporary role of this clinic, if you have one. And the next 2 slides, first, is really talking about the role of information technology. And I don't want to get too much into it because many people basically tell me, well, I don't have an information technology system, so I can't do the perioperative surgical home. That's really not accurate. It really depends how fancy do you want your perioperative surgical home. You can do a perioperative surgical home absolutely without involvement of IT, but it's just going to be more difficult in a sense that you'll have to redo it once IT is getting incorporated. You really have to think about a perioperative surgical home almost like a kitchen. Everybody can have one. You know, if it has granite in it or not, that's a different question that comes to the question if you have IT in it or not. Next question. I'm sorry, next slide. And in this slide, it just shows you a follow-up dashboard that you can again implement in your organization if you have IT. If you don't, that's okay as well. Next slide. Now, the model has been now published in a number of publications. There are more coming up at the moment. They all have shown that PSH has worked well. Next slide. It has worked in reducing the cost of joints to about $9,000 or $10,000, which is very good because the rest of the money has to come for the implants. Next slide. And in fact, if you look at data from a variety of hospitals such as Kaiser, such as St. Francis in Long Island, University of California, University of Alabama, you will see that all of them have by now have used PSH and have shown some very good results in it. Next slide. And lastly, when people ask me about money, well, here is the actual money saved. And in 2014, which really finished in July 2015, we have saved $1.6 million on a volume of about 300 joints. So that's not such a high volume of joints. So yes, you can absolutely do this and save a tremendous amount of money. Next slide. And so this is the model, as you can see it again. And we can answer now questions after Rich will do his part. We can answer some specific questions about a model, and then I can give you some information about a boot camp that we're going to have that will help you to actually implement this. So, Rich, I'm going to give it over to you.
Thank you, Dr. Kane. So first we're going to ask a question here of our audience. Do you have access to real-time data on staffing and on staff schedules?
So I got 46% voted, 54.
Okay.
Votes
are flowing in.
81. Oh, we'll call it in a second. Okay, and share. There we go.
So it looks like we have 57% of our audience does have data on their staffing, their schedules, 27% no, and then 17% uncertain. So I just wanted to take a couple of slides here to talk a little bit about what that data certainly the a lot of the discussion today is around cost, around ROI, and ways to focus on reducing those costs, and also on the working within the confines of bundled payments and the new revenue model. So one of the things that I'm very involved with is very focused on looking at things like demand history, looking at opportunities to change costs. So just a couple of things that, that we look at when we're trying to work with patients to discover opportunities to change the way operations run in each one of those areas within the perioperative surgical home. So looking at things like evaluating demand by time of day of week, time of year, local factors. We have one client who just made a couple of small changes around how holiday weeks were managed and how they were staffing. They really rolled back that staffing around around days adjacent to holidays because they realized that people didn't want to replace their knee on July 2nd or 3rd because that kind of messes up a lovely summer holiday there. So once they started to look at and really identify and get confident about that kind of variability, they were able to start anticipate it, and staff around that. So certainly looking for data from our OR systems, from billing, to really start to establish what our demand history looks like and see if there are things that we can really staff to. Also, other factors that we look at for contributing to inefficiencies. So certainly looking at use of block time versus a more sort of surgeon-centric approach to scheduling. We see certainly more and more in integrated health systems like UC Irvine, a very efficient use of block time. Surgery, as Dr. Kane said, is very much part of the team. The decisions that surgery makes has a huge effect on anesthesia, periop, and everything that is downstream in terms of those cases and things that are coming in. Doing a good job of doing things like releasing blocks. So when a surgeon is on vacation, having good information about the fact that that block is available, so maybe someone else can book their cases into it, and we're not repurposing and juggling rooms. We have a question, Jennifer?
Yeah, I think this is from one of our attendees, and this goes, I think, more to Dr. King. Says,
okay.
Does the perioperative surgical home team treat the medical conditions for optimization, or do you refer back to the PCP with a goal before surgery? She then says, example, AIC of 9, which that makes sense.
Dr. Kane?
Yes.
Sorry, did you get that question?
Yeah, so is the question about what specific hemoglobin A1C will we use?
I think the question is, does the surgical clinic, when you identify, for instance, some sort of a risk or something like that, do you treat the patient, or do you go back to the primary care provider and say, before we do surgery, we want to see this patient, stop smoking and get some exercise and make sure their blood sugar is under control. So who really owns that? The perioperative surgical home clinic or the primary care physician? So
it's an excellent question, and I'm going to answer it. Unfortunately, it depends. The reality is that it depends on how your hospital is structured. So if, for example, you are part of a larger system, then you can own it without any problems. That is, you as a pre-op clinic, you as an anesthesiologist, you as a surgeon. If you are more disjointed and you have private medical doctors who then refer patients to private surgeons who then refer them to the anesthesiologist, in which case you really need to communicate with the private medical doctors and ask them to help you with fixing things like anemia. So in that case, if you have anemia, you can't just do it yourself. And in this case, you need to communicate with the primary provider and talk to them. Now, should the surgeon do it, or should you do it? Then again, I'm going to say it depends on the structure you want to build. If you want to give the surgeon the responsibility, that's great if they're willing to do that. Typically, if they're not willing to do that, then you need to come up with a structure in your own hospital where one person is willing to take that responsibility on. It does not have to be you as an anesthesiologist. It can be you as a surgeon. But it has to be tailored based on what your hospital's resources that you have at the moment.
Terrific. Thank you, Dr. Kane. So moving on here, just a couple other things around other things attributing to inefficiencies. So certainly everyone talks about starts, turnovers, but also understanding if cases run over. Maybe you have surgeons who aren't doing a great job on their timing. Poor coordination or availability across service areas. If you have plenty of staff in anesthesia and not the right scrub techs available for that ortho case that comes in late in the day, you can't run the OR. And then, of course, we talked a little bit about inconsistent care strategies. So really using data to staff to the right levels, using that data, that historical data, to form projections for your future staffing, and also having a really solid block strategy so that at the beginning of the process, we go all the way back before we get into the intraoperative period. We're really thinking about how do we really get these cases lined up and optimized. And then just very briefly here, some of the things that are smart investments to look at cost mitigation and management. Are you making good decisions, especially in periop where you have a lot of nurses, a lot of overtime that is paid to nurses and technologists and things? So are you doing a good job of tracking your overtime and undertime and mitigating that where possible? Are you balancing your effort? Are you putting just the right information in the hands of the nurse manager who can use it instead of in some dashboard that only an executive can see? And also some of the operational things. Is it costing you a lot to calculate payroll, overtime, incentive pay? Just really understanding all those costs. And then finally, what is the true cost of providing services? And this is the thing that I'm most passionate about in healthcare these days, is really understanding for every case that you run, really being able to substantiate the real cost. What does it really cost to put those people in the room, so that you can say, well, what is my real cost for doing hips or doing a knee? So I think it's very exciting how much opportunity for improvement that there is. So I want to make sure here that we that everybody here is aware of Dr. Kane's perioperative care boot camp. Dr. Kane, if you want to take over and talk a little bit about it, please do.
Sure. So I'm sure that by now you realize that there is a bit more in the implementing the PSH or ARAS than just taking a protocol from someone. And so with that in mind, I have created this new boot camp that's going to take place in September 17 and 18. It's going to have 2 days. The first day is all about how to put it together. And the second day is all about medical conditions that we typically don't know about, such as how to manage VTE, how to manage UTI, how to manage sepsis after surgery. But mostly the emphasis is going to be really on the perioperative surgical home. It's 2 days, 26 topics, 9 faculty, and 20 hours. So as you can imagine, it's going to be a weekend immersion in this concept, and by the time you will leave that, you really should be ready to start one of your own in your own hospitals. So stay tuned for the more details of the website. Registration is going to start on June 8 and 9, and that's about it.
Okay. Terrific, terrific. So I know we're running over a little bit here, but are there any questions that have come in?
I think we did a very good job of answering them while they came in. If anyone has additional ones, please email us and we will get them to Dr. Kane or to Rich, depending on what your question is, and make sure they are addressed.
Great. And just a couple of upcoming events. Next month, Building Organizational Memory from a story from MD Anderson's Diagnostic Imaging. And then Financial Traps and OR Staffing with Brooke Staley from UVM Medical Center. And also our Becker's Hospital Review, I'll be on June 10th co-presenting with Dr. Jeffrey Beck from the Inova Fairfax Hospital, talking a little bit about compensation management and enterprise-wide efficiency. If you have any questions, please feel free to get in touch with us. And thank you very much for attending today.
And to let everyone know, we will be sending out tomorrow morning a link to the video as well as to slides tomorrow to all attendees. Thank you.
Okay. Thank you, everyone.
Thank you.
Thank you, Dr. Kane.